Good evening all to the 91st session of the Weekly Huddle. I'm your host Anoop, and joining me today is my friend and co-host Praneeth. We both are cardiologists at Care Hospitals, Banjara Hills. Most of you are quite well familiar with the format of the Weekly Huddle, so we will skip the introduction part. Today's discussion is related to hypertension management, and this is as basic of a topic as it can get. But we are trying to highlight two particular scenarios about hypertension management in this clinical case. So I request my attendees to restrict the discussion around this particular case, which is relevant in cases like these, as to speak. We are particularly focusing on resistant hypertension and patients on hemodialysis. And these kind of cases, we see it very commonly, at least in cardiology, I see it very commonly. And truly speaking, we really don't know what to do with this. It is just, and by we, I mean at least we cardiologists, at least whosoever I have spoken to, we sincerely don't know what to do. And sometimes we just kind of follow what other physicians are suggesting, and sometimes we just extend our existing knowledge in these cases. So before I discuss today's case with you, I'm going to ask Praneeth a question. Praneeth, you can answer this question in one simple word, and we are not going to judge you for that. A patient with previous cardiac problem who also is on dialysis, that patient's hypertension should be managed by cardiologist or by nephrologist?
I believe cardiologist.
Okay. So we'll get into that. As cardiologists are looking into managing hypertension, which they have expertise on it, but when the patient is spending 3 days of a week in dialysis, then the equation seems to be changing a little bit. So today's case is as follows. It's a 56-year-old male. He came to my clinic for a routine visit. He does not have any active complaints. He sees me once in every 4 or 5 months or 6 months. That is his literally visit for today as well. He has a history of long-standing diabetes, hypertension. He is on dialysis for end-stage renal disease for the past 2 years. The reason for his end-stage renal disease was considered to be diabetic nephropathy. He had non-ST elevation MI around 7-8 years back, for which he underwent an angiogram, and an angioplasty was performed to his mid-RCA. I acquired him in my clinical practice much later than that, so I don't have much details about this angioplasty. But cardiac-wise, he had been stable since I'm seeing him, so I didn't feel any need of revisiting any ischemic workup or whatnot. So in today's visit, he's doing fine. His clinic blood pressure is 170/92. His heart rate is 84. He recalls that he has similar kind of blood pressure when he goes for dialysis, where his blood pressure mostly is around 160s to 170s. He rarely checks his blood pressure at home because he gets it checked 3 times in the dialysis sessions. So he rarely checks it at home during the non-dialysis days. His blood pressure today that we have checked is his dialysis day. He typically gets dialysis done in the afternoon. I'm seeing him in the morning. And that is the numbers that I'm getting at. I'm telling you all this, maybe it has got some relevance to what we are looking at. His rest of the clinical exam is within normal limits on that particular day's visit. He comes with routine investigations, which are mostly okay, except expected elevation in urea and creatinine. His electrolytes and everything else are fine. His echo shows preserved LV function. His ECG had non-specific ST wave changes. Really, there wasn't anything which was remarkable. I am just bringing his relevant medications which are important for today's discussion. He is taking a combination tablet of atorvastatin 20 milligrams and clopidogrel 75 milligrams. He is taking long-acting preparation of Nicardia, which is 10 milligrams 3 times daily. So that's a Nicardia R 3 times daily. He takes clonidine 0.1 milligrams 3 times daily. He takes metoprolol 25 milligrams twice daily and prazosin 5 milligrams after dinner. So technically he's on 4 antihypertensive agents and the statin and antiplatelet for his stent. he is routinely instructed to skip the morning doses of blood pressure medication on the day of dialysis, and today being the day of dialysis, he did not take his morning dose of blood pressure medication. So the discussion points that I'm trying to bring today, and I don't think there is going to be any science behind it. So I'm just trying to look for what my colleagues are doing. And I also have a nephrologist with us, and Rajiv can guide us about the nephrology aspect of how we look at these patients. So the discussion points I thought are important are: number one, do principles of hypertension management differ in end-stage renal disease patients who are on dialysis versus those patients who do not have kidney disease? Number two, in such patients with so-called resistance hypertension, and resistant hypertension we can say whose blood pressure is uncontrolled in spite of being on 3 or more medication, what is the way out in these patients? And the follow-up question will be, what is the role of ACE inhibitors, ARB, or mineralocorticoid receptor antagonist in this patient subset, understanding that they are already on dialysis? And then last but not the least, the tailored drug scheduling, like what has been prescribed to this patient, where you skip the morning dose on the day of dialysis, what is the scientific rationale for it? Is it something which is a standard of care? And are we actually making it better, or are we making it worse? So these are some of the points that I want today's discussion to go. Praneeth, you can take up each of those discussion points, and then I'll have my colleagues pitch in, and later on we'll ask Rajiv for his opinion.
Yeah, Anoop. Good evening, everyone. So, regarding the management, whether that differs between CKD patients who are on dialysis or not, I am really not sure. But what I believe is managing them is difficult. It's like chicken and egg situation where at one end we have to control the hypertension well to prevent progression of disease, but these are end stage. But equally, for those who are in stage 4 or that matter, the adequate control of hypertension is important, and equally controlling the hypertension becomes difficult in these patients. And regarding how do we manage hypertension or what sort of combination that you use, most of them that I can also see are at least on these 4 drugs. Obviously, diuretics are not there. If we go by the definition, we need to include a diuretic, but I believe these patients are already on dialysis and diuretics are not there. And ACE inhibitors, it's a struggle, at least for me, that I I do not find ACE inhibitors whether that really has any difference of adding them, because there is no functional nephrons available. So I really don't know about these things. And regarding your question of scheduling the antihypertensive drugs on their days of dialysis, probably I would rely on doing a ambulatory blood pressure monitoring to see the trends of BP on a 24-hour period, to see how much is the variability there, and see whether they are significantly dropping the BP to interfere with the dialysis, and then choose the antihypertensive drugs based on that. So to have a clear-cut scientific reason or to debate on this, equally I am not very comfortable. So I'm here to learn from nephrologist today.
Praneeth, if this patient were to come to you in this particular clinic visit, given the information that I gave you, would you make any changes?
I would try to switch over from his shorter acting calcium channel blocker to a longer acting calcium channel blocker, something like amlodipine or maybe cilnidipine twice, rather than a shorter acting nifedipine or nifedipine retard combination. That is one thing. And if possible, because this patient is on dialysis, if there's any scope of adding any aldosterone antagonist, I'll try to look into it. But that again will be too risky, which I will not be doing. But probably that I could only think of changing the CCB.
Okay, all right. I'll continue my discussion. And truly speaking, hypertension management is as much cardiology as it is internal medicine. So I'll right away ask Shankar sir that, sir, if this patient was to come to you, how do you see, and if you could give your insight on the discussion points that I brought in, and what will you do for this patient?
Good evening to all. this is a very complex situation, complicated case to manage at our level. But since nephrologists are very, they are not freely available. Even ours is a district headquarters, but we don't have a nephrologist. But there are 4 hemodialysis machines. Patients are undergoing twice weekly or thrice weekly hemodialysis. So advanced CKD patients or ESRD patients, they do come to me. They seek the help of my physicians, and we try our level best to halt or retard the whatever possible progression of the CKD. We manage hypertension, dyslipidemia, hyperphosphatemia, anemia, acidosis, diabetes, and intercurrent illnesses like infections. So hypertension, now we are discussing about hypertension. Hypertension is the most common complication of the CKD. It tends to be progressive, and it is a salt sensitive also. So because of increased renal levels and as well as the exogenous erythropoietin, it also exacerbates the hypertension. So the hypertension, control of hypertension definitely retards the progression of the CKD. But here, it is a case of ESRD, already burnt out case. Only it has to go for only RRT, renal replacement therapy. So the target goals, according to the KDIGO guidelines, so the patient is diabetic, he has got a CKD, also history of coronary artery disease is there. So here we have to maintain the target goal blood pressure should be less than 130/80. So having known about these target levels and all, so a word about resistant hypertension, because already in spite of 4 classes of drugs, patient's blood pressure is still 170/92. But here our target is 130/80. So it is unfortunate, in spite of having well-established diagnostic and therapeutic protocols, more than half of the patients are not controlled to the target levels. So what is the resistant hypertension? What is the refractory hypertension? Just I will go through. Everybody knows about it, but only thinking elevated BP above the target goal of 130/80 in this case, in spite of using 3 anti-hypertensive agents from 3 different classes, including a diuretic. Here we don't have a diuretic, I think. So diuretic, thiazide-like diuretics we give in the early stage of CKD, but here it is advanced CKD, the ESRD, stage 5. So we have to depend on only loop diuretics only. If at all, if the patient has got any volume overload, sodium and water retention, we are supposed to give only loop diuretics. So refractory hypertension, where other more than 5 classes of drugs are to maximal possible or recommended dosages or tolerable dosages, even then, if the blood pressure does not come down, we say that it is a refractory hypertension. But before we say label it, it is a resistant hypertension, we have to, whether it is a true or whether it is a pseudo. So the improper technique of BP measurement and the BP cuff, improper size of, inappropriate size of the BP cuff, the poor compliance or adherence to the prescribed drugs, inadequate or suboptimal dosages, physician's inertia in this case. So if the patient is a non-adherent to the diet also, like salt intake should be, preferably it should be less than 5 to 6 grams. And if it is less than that also, 2 grams per day, most of the nephrologists, they suggest. So if the patient is a smoker, he has to stop the smoking, and excess of alcohol should be curtailed. and white coat hypertension has to be looked into. So with the ABPM or home blood pressure monitoring, we have to rule out white coat effect. So having seen all these things to rule out the pseudo, then we can go for only, we can label it as a true resistant hypertension. So the medications also, we have to take the history of medications like NSAIDs, COX-2 inhibitors, oral contraceptives. Here not oral contraceptive, but steroids. See other drugs causing hypertension should be looked into. And if there are any secondary causes also, with a brief going into the brief history, looking at the patient, like obstructive sleep apnea. If the patient is obese, roaring, snoring is there, then daytime sleepiness or the somnolence is there, we have to investigate for OSA, obstructive sleep apnea. Primary aldosteronism. This most of the times this is underlooked, but we have to investigate for the aldosteronism, especially the ARR, the aldosterone renin ratio has to be looked into, especially, and then if it is raised, we have to search for any bilateral adrenal hyperplasia or any adrenal mass. Renovascular hypertension, these are all discussed earlier. The secondary causes, chronic kidney disease, as we are tackling here, Cushing syndrome, coarctation, hypothyroidism, hyperparathyroidism, cytoma, all these things, the secondary causes, drugs causing hypertension, then pseudo-hypertensive, pseudo-resistance causes, they are all should be searched for. And when we label it as a resistant hypertension, then we have to go for non-pharmacological, like stop smoking, restrict the alcohol and weight loss and all. Then coming to the drugs, I keep this ACE inhibitors or ARBs or the MRA, the mineralocorticoid receptor antagonist, I will keep aside. Then the safer drugs like calcium channel blockers, as Dr. Praneeth alluded to, we can shift to a newer novel calcium channel blockers like cilnidipine, benidipine, and agelnidipine. So they can be tried. And instead of clonidine, sometimes it may not be available in the market, and instead of that, we can give moxonidine. I will probably the nephrologist here who is expert in this case, he will enlighten regarding the centrally acting drugs. Metoprolol, same, we can continue 25 milligrams BID. To bring down BP goal to 130/80, I prefer to increase the prazosin 5 milligram to 5 milligram once daily to 5 milligram BID we can give. Then if the patient has got any volume overload is there, we can give loop diuretic, or we can add even thiazide diuretics, especially indapamide is good regarding, it has got some renal benefits also there with the indapamide. So I add indapamide, then prazosin I will make it BID. Then instead of clonidine, I will change it to moxonidine. And instead of Nicardia retard, I will change it to the cilnidipine or benidipine or agelnidipine, which are which act on many calcium channels, L, T, P, and all. So they're renal friendly also, these molecules. So I will change them to this thing. Regarding calcium, the ACE inhibitors or ARBs and the MRAs, I will take the opinion of a nephrologist who will enlighten us in this huddle. Thank you, one and all.
Thank you so much, Shankar sir, for overview of what we should be looking and what we should not be looking. In one of this patient's past medical history, I missed, he does have diagnosed OSA, and he says he's compliant with CPAP machine. He had been using CPAP for quite a few years now. That is one key piece of information. I'm sorry I didn't bring it up during the initial discussion. So I'll go ahead during in my discussion. I will take one more view before I go to Rajiv sir. And while I pick, maybe Praveen can contribute his thoughts about this case. Praveen Nagula, if you can hear me, could you please unmute yourself and share your thoughts about today's discussion? And then maybe I'll ask Vijay Reddy sir as well for his opinion. Praveen, please go ahead.
Good evening, everyone. Sir, regarding this case, the change of the medications for the management of the hypertension, I would change the calcium channel blocker, the Nicardia. I would be happy with taking using the amlodipine. Then would be the azolnidipine rather than that of cilnidipine and benidipine. If the patient is overloaded, as already said by Shankar sir, I would be using the diuretics. And regarding the timing of the metoprolol and prazosin, I would go with metoprolol in the morning and the prazosin in the night time, rather than both being in the night time. The prazosin would be, I would be using rather than that of 5 mg BD, I would be going with 7.5 mg in the night time. Why? Because he's already on clonidine 0.1 mg TID. So using the central acting and alpha blocker in the night time would cause a lowering of diastolic blood pressure, and in the morning patient would be having the orthostatic hypotension. So these would be changed, sir, apart from the already discussed matter.
Thank you so much, Praveen. Vijay Reddy sir, if you can hear me, could you please share your thoughts? And I will ask you the question that I asked Praneeth as well. In these kind of patients on dialysis, who should be managing hypertension, cardiology or nephrology? And your opinion about what we are discussing.
Good evening, everybody. It is a combined approach, both from cardiologists and nephrologists. Here, this case is a resistant hypertension in a patient on ESRD on hemodialysis. So, the most common cause for this is the volume overload, though there are other mechanisms like sympathetic overactivity, renin-angiotensin activation, vascular stiffness, endothelial dysfunction. All this may contribute, but the majority of the reason for this hemodialysis patient, because of refractory hypertension, is volume overload. Number two, regarding the 24-hour ambulatory monitoring in a hemodialysis patient is not a practical thing. So home BP monitoring is a better choice when compared to 24-hour BP monitoring. The first and foremost drug in a patient who is on maintenance hemodialysis is a beta blocker. Then dihydropyridine calcium channel blocker. But don't give dihydropyridine calcium channel blocker alone, because it causes vasodilatation of the afferent glomerular arteriole, which increases intraglomerular pressure and causes further renal damage. Any calcium channel drug of dihydropyridine, whether it is nifedipine or amlodipine, or both are effective. The third drug I want is apart from beta blocker and calcium channel, is a alpha blocker. Fourth one is a centrally acting drug like this clonidine. And the role of RAS inhibitors is basically to halt the progression of the renal disease. Already it is a end-stage renal disease. There is no question of further worsening of the renal function. So the role of RAS is not ideal. And so These are the limited, and the home BP monitoring is ideal, and you should be under 24 hours ambulatory is not a practical in a hemodialysis patient. Thank you.
Thank you so much, Vijay sir. And I will get to Rajiv sir now. As you all know, Dr. Rajiv had been in our huddle before. He is a nephrologist practicing at Sunshine Hospitals. Rajiv sir, you heard a lot of viewpoints about how we are going to manage both from cardiology as well as from physician standpoint. I will tell you my impression on what I always used to think. So in my opinion, a patient who is on dialysis, if that person's blood pressure is uncontrolled, and what I concur with what Vijay Reddy sir said, that in my I always had this thought process that most of the time it is volume mediated, most of the time it is volume mismanagement, or I wouldn't say mismanagement, just under management. I would say that this patient probably needs a little bit more aggressive dialysis than an aggressive dose adjustment of the blood pressure medication. Having said that, if the same question would have asked to me that blood pressure management, cardiology versus nephrology, I would have said that if the patient is on dialysis with no active cardiac issue, then I leave it on nephrologist to manage the blood pressure, because the volume status I cannot manage by giving diuretics and whatnot. So if I could get your thoughts about what is this volume doing with dialysis patient, is it a real deal? Is it too much over amplified? And if you could also highlight the questions that I have put in the discussion. And once you do that, I also have few follow-up questions that has come across. So Rajiv sir, the floor is yours for the next few minutes. Please take it over.
Yeah, thank you, Anoop. Thank you, Praneeth. And it's always a pleasure to follow Vijay Kumar Reddy sir. I entirely agree with what sir has said. There are a few things I would like to add. Firstly, your patient with a BP of 170 pre-dialysis, your problem patient is more like a well-managed nephrology case, to be frank, because what we see in dialysis units is blood pressures of 200, 240, people coming in pulmonary edema. Looking at your index case, there are a few questions I would have. One is, what exactly is the hemodialysis prescription that this patient is on? And the reason for that is, it makes a difference whether he's on twice weekly or thrice weekly. For somebody who is on twice weekly, I would expect the blood pressure to be more of a problem in those patients. For somebody who is on thrice weekly, I would expect intradialytic hypotension to be more of a problem in those cases. I would also like to know what is the interdialytic weight gain in this person, because that tells me how compliant he is with salt and water intake. Most importantly, what exactly is the BP we are looking at when we decide a clinically significant parameter to target? Clinicians tend to look at pre-dialysis and post-dialysis BP. And there's a U-shaped curve associated with mortality with those things. But the one value which is almost like a straight line in a linear regression model, which is associated with mortality, is the midweek home BP. Okay, so ideally you would need to be doing ambulatory blood pressure monitoring to detect hypertension in those cases, but that is not always practical. So the next thing we can do is actually look at the median week BP, which is actually intradialytic. You put patients on dialysis, and after 1 or 2 hours of dialysis, in the middle session of the week, you look at their BP. That is probably clinically more relevant. The other thing I would look at is, what is the urine output that this person is having, and that tells me a few things. If this person has quite significant urine output, which is often the case in people who have chronic interstitial nephritis as a cause of their renal failure rather than chronic glomerulonephritis. These patients are still amenable to diuretics, but like Dr. Shankar was saying, yes, you do need to use loop diuretics, and that too at very high doses, nearly ceiling doses. But you can also add a thiazide diuretic, specifically metlazone. What we as nephrologists are looking at is, what is the dry weight of the person that we are targeting? And this dry weight has, this term has acquired quite a mythical value in nephrology circles, mainly because nobody has seen it, but everybody is looking for it. So what we mean by dry weight is that blood pressure, I mean, that clinical state that you have at the end of dialysis where somebody is neither euvolemic nor, hypovolemic, is not hypervolemic or hypovolemic, and they have normal blood pressure. There was a study in Turkey nearly a decade ago where they looked at dry weight, and they went about ultrafiltering patients in a very systematic way, taking out a little bit more fluid every dialysis session until they reached a point where they were able to take patients off, BP medications. And this is possible. The reason for that is that a dialysis patient like your index case, who's been on dialysis for 2 years, probably has very little urine volume left. And his body is essentially a closed system that is exquisitely sensitive to sodium and volume. And you can achieve measurable drops in BP just by targeting volume removal. As somebody also mentioned, you can look at what erythropoietin stimulating agents they are on, because those are associated with hypertension. And again, it also depends on whether they are getting the ESA drug intravenously or subcutaneously, because the bolus administration of the drug can cause a spike in blood pressure. And I would also look at the hemoglobin level, because if their hemoglobin is more than 11.5, that tells me that they are probably receiving more erythropoietin stimulating agents than is necessary. One question that is often lost sight of in dialysis patients is what exactly is the native kidney disease they came here with. Too often we just assume it is either diabetes or hypertension or chronic glomerulonephritis. But if you go around dialysis units, around 5 to 10% of cases will be having autosomal dominant polycystic kidney disease. And these patients, although the kidneys are dead, the cysts are still alive. And these cysts are producing hormones. They tend to have a higher risk for renal cell carcinoma. In fact, all dialysis patients should be screened once a year for renal cell carcinoma. And these cysts do tend to produce hormones which affect your blood pressure. The medications list that you've given for your patient, one thing I've noticed is this: all of them are either short-acting drugs or dialysable drugs. So drugs like clonidine, drugs like metoprolol, nicardipine, all these drugs are dialysable drugs. In dialysis patients, we would prefer an ARB rather than ACE inhibitor, simply because an ARB is not dialysable. We would prefer amlodipine rather than nifedipine. We would prefer carvedilol, let's say, rather than metoprolol. Although studies do show that metoprolol has probably a better effect on mortality. Atenolol is a really wonderful drug that you can use, which does control BP very well, but you have to dose it after dialysis thrice a week. So that's again one nuance we have to get right. So the most important thing in dialysis patients, like everybody has been saying, is volume control, volume control, volume control. But today we don't have very good scientific methods for figuring out what exactly is the volume that a person has. There are things that if you have a very compliant critical care staff, there are things you can do, like doing a lung ultrasound. In the West, they have moved on to doing bioimpedance analysis. And that's, I think, something which is the way of the future, especially if you have bioimpedance analysis that is multiple frequency or, bioimpedance spectroscopy. And you can actually do a vector analysis, bioimpedance vector analysis, which will help you differentiate whether the clinical overload that you're seeing is actually, is it really overload, or is it because this person is malnourished and his serum albumin is barely 2? So I think that's one thing that will help guide accurate target or accurate removal of fluid in the future. Is there something I have missed? Please feel free to jump in.
Okay, sir, all the things that you said, I don't think any of those comes to at least my thought when I'm seeing this kind of patient. So you have to bear with me. I'll have to dissect one at a time. And I'm sure there are cardiologists who are far more smarter than me who are looking at all of these when the patients come to them for hypertension management. But all the things that you told me, they are literally they are bouncers for me. So I will try to answer a few of the questions that you first put in, and then I will ask you a few questions. You mentioned about hemodialysis schedule. This patient is on 3 times a week schedule that I know. I know his urine output is none. He says very minimal. I don't know his dry weight concept. I don't know what is his dry weight. He does not get dialysis done in my hospital. And he is on erythropoietin. I cannot recollect what dosing he's getting. And I never knew that IV versus subcutaneous has got an impact on hypertension. So I never looked into that as well. His most recent hemoglobin was 10.5 that he got in the labs that he came with me today. So those were some of the questions that you asked, for which I have provided you the answer. One thing that you brought which interests me, dialyzable drugs versus non-dialyzable drugs. I would assume that, like, I have never studied dialyzable drugs. I know that there are drugs which are hydrophilic, so they are renally excreted. There are drugs which are hydrophobic, which are not renally excreted. I can differentiate drugs based upon these two criteria, but I cannot differentiate drugs between dialyzable versus non-dialyzable. Is it okay to assume that drugs which are hydrophilic, they are the one which are dialyzable, and vice versa? Is it a fair thing, or I have to look at a new chart? Rajiv sir.
It's actually got something to do with protein binding and a few other characteristics. But in general, among calcium channel blockers, the so-called, starting with the non-dihydropyridines, the amlodipine, cilindipine, all these drugs are not dialysable. ACE inhibitors as a class of drugs to a certain extent are dialysable, but it depends upon, some are more dialysable than the others. But in general, once a person is on dialysis, we tend to switch them over from ACE inhibitors to ARBs. None of the ARBs are dialysable to any significant degree. Among beta blockers, propranolol I think is not dialysable. Metoprolol is dialysable. Atenolol also is dialysable, but atenolol, the half-life is prolonged once somebody is having ESRD. So it really makes sense to give it post-dialysis. Carvedilol is not dialysable. I think nebuvolol is not dialysable. All these drugs, hydrolazine, all these clonidine, all these drugs are dialysable. So we do tend to have this phenomenon during dialysis wherein a patient will develop intradialytic hypertension. He starts off with BP of around 140, 150. And in the middle of dialysis, you'll get a call saying his BP has now shot up to 200. There are various factors. I mean, one is the activation of the renin-angiotensin system because you've removed a significant amount of volume. But also, it's the fact that the drug has been cleared by dialysis, and now this person is exposed to a situation where they don't have a functioning drug in their blood. So yes, it does make a difference whether the drug is dialysable or non-dialysable. Having said that, even dialysable drugs are clinically useful, like atenolol, which Vijay Kumar Reddy sir was saying. Metoprolol also is clinically useful in a dialysis patient. The use of drugs like ARBs or mineralocorticoid receptor antagonists, the incidence of hyperkalemia. My problem is that these patients are already at such a high cardiovascular risk, and they've already probably suffered the effects of whatever cardiovascular damage they're going to suffer. Studies have not shown a significant mortality benefit simply because these patients are on ARBs. Correct me if I'm wrong. But having said that, for whatever benefit this drug can give, I would say the risk of hyperkalemia in a regularly dialyzed patient is overblown. We do not see hyperkalemia as a main problem with these drugs because they don't have functioning nephrons. For them to have hyperkalemia secondary to these drugs, you need the actively functioning nephrons to retain potassium, which they don't have. Even the potassium is kind of in a closed system. So if they're not taking high amounts of potassium and you are dialyzing, and dialysis is a wonderful way of removing potassium, they generally don't have clinically significant hyperkalemia, especially if they are on thrice a week hemodialysis. And having said that, there are things which uniquely you as a nephrologist can do both to manage hypertension and hyperkalemia. One of those things is you can control the level of potassium in your dialysate. The other thing is you can control the amount of sodium in your dialysate. If you go to dialysis units, you will find that most of them leave the standard prescription of 140 as the dialysate sodium, which basically means that at the end of dialysis, your patient's sodium is close to 140. You have removed, and dialysis technicians tend to do this because when the dialysate sodium is higher, there is less chance of intradialytic hypotension, which patients really get worried about and which can compromise the vascular access they have. But the downside is that you now have a patient with a very high serum osmolality who has a raging thirst at the end of dialysis, and this person is going to drink water, and this person is going to drink water until his serum osmolality becomes normal and his thirst centers are quiet. And he'll come back to you the next dialysis with 3.5 liters as the weight gain and probably a BP of 180 or 190. So the thing you can do is actually slowly reduce the dialysate sodium. Machines can reduce dialysate sodium all the way up to 135. In patients in whom resistant hypertension is an issue, this is one of the things you can do. If you go all the way to refractory hypertension, and we do have a few patients like that, there are some last-ditch drugs we do try, like hydralazine and minoxidil, which do work. But I would say these patients either probably need a transplant or they need more effective counseling on how to manage their, salt intake. Fluid intake again is very, very intimately related to salt intake because you cannot control thirst unless you control sodium intake. And they drink in response to their serum osmolality. And the serum osmolality in turn depends upon their serum sodium levels. In a closed system, that in turn depends upon how much sodium they're taking. So these things I think we need to keep in mind. We can switch the prescription around with the factors that we've been talking about, but ultimately it is volume control, volume control, volume control.
So I will continue to ask questions from Dr. Rajiv that has been discussed so far. In the meantime, if you do have anything to add, please you can raise your hand or you can type your question in the chat box. So Rajiv sir, is it so? If I may try to oversimplify things, as a nephrologist, you like more dialyzable drugs or you like more non-dialyzable drugs or you like a combination of both? If you have to make a simple statement for this.
Because hypertension is universal. I mean, if you look at Western textbooks, they will tell you that hypertension is around 60% prevalent in dialysis patients. But in practical experience, it is 80 to 90% prevalent. So it's a universal problem. And so we prefer non-dialyzable drugs, except in the patients who are developing, hypotension at some point, in which case we kind of tend to switch to shorter acting drugs, and most shorter acting drugs tend to be dialyzable.
Give us a rationale of why a lot of patients are told to hold their morning antihypertensive drugs when they are coming for dialysis.
Yeah, so one of the things is dialysis technicians are very scared of a normal blood pressure. If you have a dialysis patient who is turning up with blood pressure of 130 and he has an intradialytic weight gain of 3.5, it's really scary. In theory, the dialysis technician is supposed to remove all the fluid that the patient has accumulated in the last 2 or 3 days since the last dialysis session. And it's very scary for a technician to put an ultrafiltration of 3.5 liters for a patient who's having blood pressure of 120. And they are scared about two things. One, this person is going to develop hypotension, loss of consciousness. The other thing is that this person's fistula is going to go for a toss. Because many of our patients have, even after years on dialysis, they tend to have poorly developed fistulas. Some of them have thrombosis from, poor cannulation technique and all that. And they too tend to depend upon having a blood pressure of around 140, 150 to be safely patent open. So it's like, I would say the best analogy is, the nurse in the ward for a patient who has normal glucose levels would be quite squared to give the usual prescription dose of insulin, which may be around 35 units. So our dialysis technicians tend to ask them to hold the morning doses of, BP medications, simply because they are more scared of intradialytic hypotension rather than hypertension. Hypertension they can manage; they just have to increase the ultrafiltration.
Talking about technician and nurses and whatnot, in Indian practical scenario, how frequently do these patients see their nephrologist when they are going for dialysis? They are going 3 times a week, but how frequently are they seeing nephrologist?
Yeah, so it depends from center to center. In my hospital, I see all my dialysis patients every time they come to dialysis. So it may be 2 times a week, 3 times a week. So I see them. But there are some legal issues also, in the sense that there are government rules for Argashri patients, and you do have to see them as a minimum number of times. And I think a few months ago, it was around once in a month is enough. Okay, so when you have these standalone dialysis units which are not connected to a hospital, the incidence of a nephrologist visiting them is a patient is probably once in a month or once in a couple of weeks. But ideally, every patient should be seen at least once during a dialysis session.
Now, some very specific questions related to medications. The scenario is end-stage renal disease, on dialysis, minimal to no urine output. Role of thiazide diuretics in such patient? Any role or none role?
If the person has nil urine output, there is, I would say, no role of diuresis in those patients.
Because thiazide diuretics, we talk about it doesn't just work with diuretics, but it has got other effect as well. But do you think it literally has got no effect in such cases?
In terms of volume control, I would say we generally don't. The only thiazide diuretic we use in a dialysis patient is metrazone. And if at all we do use a thiazide diuretic, it is on a non-dialysis day with high doses of loop diuretics to kind of squeeze out, whatever volume of urine we can get. But you do have absolutely anuric patients, and if I am going to control blood pressure in those patients, I have better drugs than thiazide diuretics, so I would not use in those patients.
So same patient scenario, the role of RAS blockade. Now the nephrons are not working, or at least we are assuming it is not working. You said you prefer ARB over ACE inhibitors, and you said you are not worried about hyperkalemia when you put them on mineralocorticoid receptor antagonist. But role of such drugs in blood pressure control when nephrons are not working, do these drugs actually work?
Yeah, so they have a modest effect. This is what we notice. They may bring down your blood pressure by around 3 to 5 mm. And the mechanism for me is not exactly clear, because obviously the angiotensin receptors are there throughout the body and not just in the kidney. Perhaps the effect on vasculature elsewhere is having an effect. But in anuric patients who are on maintenance dialysis regularly, who have a decent handle on their potassium intake, hyperkalemia is not a problem. There is only modest effect in terms of BP lowering when it comes to ARB use. So we tend to kind of see whether this drug is being given for some cardiovascular benefit. And if it is being given for that, then we continue it. But again, in terms of absolute BP control, I would say probably atenolol and your calcium channel blockers are more potent.
Thank you so much, sir. We are going to wait for our attendees if they have any questions. And while I do that, I will ask Somaraju sir for his opinion and suggestion about today's discussion. Somaraju sir.
Thank you, Anoop. And it's a very important issue you brought up, and most of the issues are already addressed. I'll just address the issue of importance already mentioned by the nephrologists and other colleagues, namely the dry weight. Dry weight is not easy to define, but when we say a patient has a partial hypertension, weakness, giddiness, and then cramps and all that, that before they develop it, we should detect it. One of the ways some of the units and do that is with the availability of ultrasound everywhere now, the lung water can be assessed, and that helps in assessing the so-called dry weight we are looking for. And second is the beta blocker that we generally prefer when you have difficult to control hypertension in these patients is Etinolol. Etinolol is more effective, and metoprolol is hardly it doesn't control blood pressure at all in the ordinary routine doses. And then etinolol will be the drug of choice. And in patients with renal failure, depending upon dialysis and other issues, it's often given alternate days, 25 to 50 milligrams, etc. And then, so on use of diuretics in patients who are passing some urine, there is when you say thiazide diuretic, the terms used are thiazide-like diuretic and thiazide diuretic. Thiazide diuretic, like say, routinely we use thiazides, they are not helpful. Chlorthalidone or indapamide maybe better choice. They can be combined with loop diuretics also. So I leave it here. Thank you.
Sir, there was
I suggest when you have a difficult problem like this, you should have a clinician meeting with a nephrologist and cardiologist and others, whoever is needed, once in a way in a difficult patient.
Right, sir. In fact, the whole purpose of the weekly huddle was to have that kind of formal discussion amongst speciality where we share our thoughts. Somaraju sir, I have one question for you which has been brought on the chat box, and I thought who would be a better person to answer that question than you. There are two questions which are actually asked. I'll combine both of them. They both are pretty similar. The one question is, what should be the ideal dosing interval between different groups of drugs? And I guess the question here is, when we put patients on multiple antihypertensive medication, often what we end up prescribing is morning dose and evening dose. Are we actually suggesting that they can take all the drugs once in the morning and all the drugs once in the evening, or we should actually tell them to space out various drugs, different classes of the drugs for morning hours and again spacing out in the evening hours? And a similar question is about risk of orthostatic hypotension and dosing prazosin and clonidine. Should we be doing some kind of dose adjustment morning versus evening so that we can reduce orthostatic hypotension incidence? So Sumaraju sir, if you could highlight your thought process, how do you advise your patients to take such medications?
It's a very important issue that's brought out. It's very one of the issues with patients with chronic kidney disease, renal failure is they are typically non-dippers in the night. There is a nighttime dip in blood pressure in otherwise routine hypertensions we treat in the absence of renal failure, etc., or obstructive sleep apnea, etc. So if the patient is a non-dipper, as in chronic renal failure like this, there has to be one drug at least given in the evening or night time to take care of hypertension in the night. That's important to keep in mind. So it should not be just one day dose. There has to be an evening dose to take care of the lack of nighttime dip in patients with kidney disease. Thank you.
And sir, what do you do for the morning doses where sometimes they end up taking 3-4 blood pressure tablets at the same time? Is it okay for them to take all 3-4 at the same time, or would you suggest to space it out every hour or 2 hours, something like that?
See, typically many people answer this. Ambulatory blood pressure will answer this question, but it's a difficult thing to get ambulatory blood pressure. There are some unreliabilities in it. As is already pointed out by somebody, home blood pressure is the best method. And in such a patient, ask them for a week or so to check blood pressure morning, evening, or afternoon, depending upon the way the blood pressure is behaving. Decide on the frequency of doses and timing of doses of the total number of drugs you are giving.
Perfect. Thank you so much, sir.
If I might
Anybody
add,
have
Dr.
yes,
Anoop,
yes, Rajiv, sir.
yeah, we to add on with what sir has been saying, we do see this actually quite a lot, especially among patients with diabetic autonomic neuropathy. And these patients tend to have trouble both ways. Their BP will be around 180, 190 when they're lying in bed at night. And when they come to the dialysis unit in the morning, their blood pressure is, 100. Um, the degree of orthostatic hypotension they have is actually quite significant compared to even our traditional understanding of orthostatic hypotension. So the way we manage these cases is we tend to put them on these short-acting drugs at night. So something like losartan, captopril, if you can still find it, clonidine, okay, hydralazine. So we tend to put them on 3 or 4 short-acting drugs at night and take them off all medications in the morning. And what we notice is that they come in walking with BP of 100, and once they lie down on the dialysis bed, again their BP shoots up to 160, 170, 180. But that's something which our technicians can manage because they just have to ultrafilter them at that point. So, so this is our clinical experience with this.
Perfect. Thank you so much, sir. It's 8 o'clock. Anybody has got any other comments or questions? I believe I have taken all the questions in the chat box. Praneeth, your closing comments for today's discussion.
We have not discussed renal denervation.
Sir, we actually had a huddle discussion on ischemic nephropathy. We did briefly touched upon the concept of renal stenting, and we didn't discuss renal denervation in detail.
Do you have any experience with it?
I personally don't have an experience in a commercial case. We were part of Simplicity trial in US where I was trainee. But of course, the world has
that was a negative trial, right?
Yeah. But the world has significantly changed from the single port Simplicity catheter to multi-port catheters that are currently being used. So the spiral catheter that Medtronic provides, that is actually far more efficacious, and we will come back with one of the weekly huddles where we will be exclusively talking about renal denervation, the data behind it, why it failed, why the current thing looks very promising, and we will talk about how we can put it in perspective of normal kidney, CKD, and end-stage renal disease. So that is in my homework. I just wanted to make sure that we have got some clarity about availability of the device. Still now it is not easily commercially available. Cost is a little bit prohibitive, but we do want to discuss about renal denervation. Ischemic nephropathy, we did talk about in detail in one of the previous discussions. That is already uploaded on the YouTube. So we will get to it. Praneeth, your closing comments.
Yeah, so a lot of points that I learned, most importantly about looking at the drugs that are dialyzable versus non-dialyzable. I never thought of looking into it. Maybe I'll put a printout and I'll look into it the next time when I look at these patients. One important thing that I learned about the importance of atenolol. I thought atenolol was obsolete now, at least from the cardiology space, but in combination with CKD on dialysis, I think atenolol deserves its place in the prescription. And the other point of usage of mineralocorticoid receptor antagonists again is possible, which I'm okay discussing with my nephrologist and try to include it, because at least in cardiology space, these drugs have shown to be having a significant mortality benefit. And the importance of volume has been highlighted by Dr. Rajiv as well. So that I think is the onus on each and every one, no matter which specialist that he's seeing, because educating the patient on sticking to the volume is something that we need to look into it. And I believe sometimes we also should look into the basics of how dialysis circuits are being done from a technician's standpoint of view, which helps us understand how actually dialysis is being done, and probably know from them what is it that they want. So knowing about the intricate details of dialysis circuit and how things are done also should probably help us. So walking around in dialysis units will probably get us more insight on managing these patients better. So a lot of points that I could get from today's session. Anoop.
Thank you, Praneeth. Thank you, Rajiv sir, and thank you everybody for attending today's discussion. I must say that there were a lot of learning points for us. I certainly have to go back on the internet and do a little bit more of reading, and definitely I'll be able to take better care of these patients when I see in the future. As you all know, we are doing this weekly huddle every Wednesday on at 7 o'clock. I'll see you next Wednesday with a new topic. If you have a topic that you think we should cover on our weekly huddle, please let me know. And our previous episodes are uploaded on YouTube, so you can listen to them during your dead time. Thank you all. Good night. I'll see you next Wednesday.
Thank you. Good night.